My name is Gina Remington, and we're tonight going to be talking about pain management and multiple sclerosis. Now, this is from a nurse's perspective because I myself am a nurse. I've been in multiple sclerosis for almost 9 years now. I work at UT Southwestern Medical Center in Dallas, and we're right in the heart of Dallas. I work with Dr. Froman, Dr. Greenberg, Dr. Graves, and Dr. Flores. If you've heard of any of them, a lot of them have done a lot of speaking at various conferences and do grand rounds with physicians across the country. And we also have a training program within our clinic that each year is funded by the National MS Society, and we have the opportunity to train physicians, nurse practitioners, nurses, and physician assistants from across the country. And we are looking at expanding that program to include social workers, PT and OT, and other members of our healthcare team that we think are a crucial part of our team when seeing our patients with multiple sclerosis, so that I can answer them at the end. I do also, before I begin, want to thank Lisa. She's really been the spearhead of organizing this webinar for you, and I think it's a great way and cutting-edge way to use technology to allow for a lot of different people to not only hear and participate in the discussion tonight, but also for those of you listening at a future date. It's nice to have this type of opportunity, and for you not to just hear my voice, but to also see what I look like, so that hopefully we can engage as colleagues in other meetings across the country. And always feel free to stop and ask and let me know that you were on the teleconference so that we can even meet in person. And I also want to thank Mobility Research for helping coordinate the technical aspects, especially for me as I'm getting used to doing this for the first time. I use a lot of social media and I'm interested in technology, but this is my first webinar where I've not only been able to speak through the audio, but to be able to be seen by those that are participating. So I do want to emphasize tonight that this is from a nursing perspective. The reason I think that's important to underscore is because a lot of you, like myself, we're not prescribers. But we see these patients with multiple sclerosis and we want to help them. And there are a lot of things that we can do to advocate for the patients and to help educate them and empower them to help deal with symptoms that they have. And one that I think is crucial in trying to manage is their pain. And so Lisa had asked if I could talk about the etiology of MS-related pain, the pharmacologic treatments, the non-pharmacologic treatments, and then have a good question and answer session. So hopefully tonight the goal is to provide specialists in rehab like yourselves with the knowledge of medical and behavioral pain management for patients with multiple sclerosis. And we really have two objectives tonight. Upon completion of the program, hopefully you'll be able to demonstrate an increased awareness about the causality in patients dealing with pain as a symptom of MS, and hopefully you'll be able to talk about the development of some fundamental strategies for treatment of pain management in patients with multiple sclerosis. And a lot of times these concepts too can overlap with patients that you may also see that have other demyelinating disorders. So let me see if I can get my slides to advance here. My mouse is stalling here, so I apologize for the delay. Once I get it on the right spot, I'll leave it there so I can... Okay. All right, can everyone see that okay? Did I advance okay? Mobility Research, if you could just let me know. This first slide talks about points to remember. And I'd like to point out first, before we kind of get into the nitty-gritty of pain, one thing that's really important is that pain has not always been associated with MS, and we've made a lot of progress since the late 1990s and now into the 21st century, dispelling this myth that pain is not associated with MS. We now know that it is, and we'll talk about this in a little bit, but pain can be a primary reason from the central nervous system for why these patients are experiencing these sensory disturbances. And until the 1990s, this was just a myth, and I think patients, not necessarily they were neglected, but I think that there wasn't a lot of research, there wasn't a lot of evidence-based medicine showing that there are ways to help patients with multiple sclerosis deal with their pain, and that there are interventions that can overlap with some of their other symptoms in helping treat them so they have increased quality of life. And that is always our goal. Now, if you look at the prevalence, I think this may change as we conduct more research over time, but if you look at the research, there's a broad span of figures that you could probably come up with, anywhere, depending on which article you read, from 35% all the way up to 80% of patients that experience or complain about pain at some time during their disease course. And so I thought I would reference one reputable source from Celero that you'll see that at the bottom of your screen, where it seems like the mean average of prevalence percentage-wise, if you were to look at these more reputable sources in the media, looking at published sources, the mean does usually look to be somewhere around 63. This particular article quoted 63.5% of patients that were complaining of pain sometime throughout their MS diagnosis, which is obviously a substantial number that notes taking care of this issue for our patients. Now, ethnicity is not a risk factor specific to pain, which means that if you have someone of a certain phenotype or a certain demographic, ethnicity is not a risk factor for increased pain. However, I would like to remind you that if it does seem like you have patients that maybe fit a certain ethnicity, and you do think that maybe pain is more popular in those patients, I want to remind you that probably from Dr. Pardo's talk, I know he did the MS 101 a few weeks back, and if you do remember, we do have some evidence to show that patients that fit a certain phenotype, specifically those that are African American male patients, we know that when they're diagnosed with MS that they can have a more aggressive form of MS, and those red flags do pop up when we see those types of patients, because we are on high alert to make sure that we can manage those patients sometimes more aggressively, because they do trend to have more aggressive disease. And so you may notice that because their progression is more escalated, or that their disease course is more aggressive, that they may also have more issues related to pain. But it's not necessarily due just to ethnicity alone. It's probably because of the type of MS disease course that they're exhibiting. It has been reported that MS pain is more intense, and this is in reference to not only the general population, but also other chronic illnesses that also express or exhibit pain-related or sensory type of symptoms. And again, our goal is quality of life, and this is why the pain has such a huge impact on our patients, because as we'll talk about, it has a lot to do with a lot of our other symptoms that we affiliate with MS. So what do we know? We know that pain's important. We also know that now we incorporate it into our vital signs. At our medical center, when we take blood pressure and we take heart rate and weight, we also ask the patient about pain. And we know that there are numerous scales and questionnaires to track pain, especially in research. One that we use often and we see often in large clinical trials is the quality of life, the QOL 54. It's a 54-item questionnaire that the patient fills out, and there is a section of it in there that asks about the last 4 weeks, and it does ask specifically about how pain has affected patients' symptoms related to MS. So what else do we know when it comes to pain? Well, I want to give you some good references if you want to look up some of these as evidence for what we're talking about tonight. One of them is from Numiko's group in 2008 and 2010. Both of these kind of overlap as far as references, but pain can be traced to alterations in the CNS. And this is really, really important, because just like dispelling that myth that we talked about, we do know that pain can directly be traced back to those lesions and those plaques that we know are causing multiple sclerosis, and that these track systems that are involved can directly lead to symptoms like pain themselves. So it's not just necessarily a secondary issue that the patients may experience, which we'll talk about, but that it can be directly traced back to alterations primarily in the central nervous system themselves. We know that pain can be severe and it can occur in multiple sites. And something that I think is important to remember when assessing our patients is that the patients can have more than one pain syndrome at one time. And we're going to talk about the different causes of pain, and you'll see why this can occur. But when trying to parse out what those symptoms are and how to treat those patients, it's important to keep in the back of your mind that there may be more than one pain syndrome going on, and we need to be able to identify the etiology of these so that we can give the patients adequate treatment and track them well over time in a systematic way. And so understanding that these can occur at multiple sites and can be more than one pain syndrome occurring in one patient at any given time is very, very important. Now, the most common type of pain syndrome in MS, and I apologize for some of the redundancy in here. For some reason, some of the words are typed there a couple different times, but the most common type is these burning sensations, continuous burning in the extremities. Some patients may notice that it's more tingling. We'll talk about some numbness and some other descriptive words that the patients use. Patients can complain of headache, back pain. And just like you heard, I think, a couple weeks ago from Amy, tonic spasms and spasticity can be very painful. We also know that this symptom of pain is very important because it can also increase all these other symptoms that our patients can exhibit. And those symptoms would include fatigue, anxiety, distress, attention span, concentration, memory, learning, depression, and we can clump all of these different symptoms into a category that we know are affected by pain. And so then we often try to reduce pain because then we think it may also help decrease the level of fatigue that the patient may have, help with some of their mood disruptions, and also help them with their cognitive dysfunction, because we know in MS the most common type of cognitive dysfunction is processing speed. And we know that if someone's in pain, then your concentration is affected and then your processing speed is that much slower. And so if we can help the pain and relieve some of that, then we know that it's also going to help the myriad of symptoms that also is associated with multiple sclerosis. And then finally, one thing that's well documented is that although we've made progress in research and in the symptomology of MS and as it relates to pain, we know that it's still insufficiently treated. And I think part of this is because patients can have more than one syndrome, they can report it in various ways, and it's hard to kind of pinpoint a consistent way to describe pain and to track pain over time, and to know exactly where it's coming from in the body. And so there's insufficient evidence for current treatments, and we do have a good menu of options for patients to try, and we have to usually seek out multiple approaches for treating pain. But we still need a lot of evidence in the literature to help progress this field and to help our patients with this sometimes horrific symptom. So how do patients describe pain? Well, if you look at some of the key words that are used by our patients, I would say that the most common ones you'll hear is that it's really a nagging system, it just won't go away, won't leave me alone. More commonly, you'll hear about burning and tingling. You may hear about an electrical shock, and we'll talk about what that may mean. And you'll also hear about this heat sensation. And I think that goes along with the burning. And so we try to classify, at least myself as a nurse, when dealing with patients on the phone or talking to them in the clinic, we try to categorize based on what they're telling us. How do we translate that into a category where then we know how to treat these patients that are having these symptoms? And so I've wanted to give you a few different quotes that maybe you'll hear from your patients, and that'll kind of help tell you whether or not you're dealing with a central neuropathic sensory symptom or whether or not you're dealing with something else. And so some things you may hear are that the patient feels like their skin is on fire. And I'm sure a lot of you are very familiar with this type of a symptom. We know that this is neuropathic. There are ways so that we can try to treat this. Another thing the patient may say is that they have a tight band around their middle. And you may have heard from Dr. Pardo's talk in the MS 101 that this describes what we sometimes also call as the MS hug. The patients feel like they have this tight squeezing around their chest or around their abdomen, and so they have this tight band sensation around the middle. And this is very key to pick up on, because if this is new, and we'll talk about triaging symptoms, this may directly relate to a spinal cord lesion, and if it's new and enhancing, then we want to pick up on this type of a relapse to help the patient, and this can be indicative of that. The patient may also say that the side of their face hurts so bad that they can't even brush their teeth. Now, this is something that I often train nurses and anyone picking up the phone to talk to our patients about, that if you hear anything like this is something that needs to be addressed right away. This is usually a sign of trigeminal neuralgia, and we'll get to that a little bit later, but this is the type of symptom where the pain is so severe that the patients will describe to you that it feels like they stuck the side of their face into an electrical socket. And it's just one of those things that I feel like I immediately want to address, because I can't imagine sort of trying to live throughout the day with a symptom like this. And this one here talks about brushing their teeth, but a lot of times I'll have patients tell me that just going outside, if it's a breezy day, just the wind touching their face is enough to elicit this strong electrical shock-like sensation in the side of their face. And so we immediately act on that to try to get these patients started on the treatment so that we can alleviate these symptoms. And then sometimes you'll hear that patients will say that their feet are numb. And so this is common, obviously, with numbness, tingling, more of that neuropathic type of sensation. But I do want to point out that this says my feet are numb, but it doesn't always have to be both feet at the same time. As you'll remember probably from your MS 101, that MS is not something that's a very homogeneous type of disease. You can have patchiness, and it could be one foot and one hand, it could be one arm, it could be patches on the abdomen or the back. It doesn't necessarily fit any type of pattern, but numbness is very common. So if patients start talking about how I ache all over, or my back, my hip, my knee hurts, then we start to think about maybe this is non-neuropathic and there's some other sensory disturbance that's going on that could be related to MS, but we also want to know that there are a lot of other things that can cause pain, even though a lot of the times our patients are talking about how they blame MS first. It's not always related to MS, and there could be some other process going on, like infection, arthritis, and we need to investigate those things as well and keep those in mind when patients are trying to describe their pain. So what are the causes of pain? And before we get into the very specifics of the different types of pain, I just kind of wanted to tell you a little bit about how we try to categorize them. And we deal with the categorization as being primary, secondary, and tertiary. So just like in the section on the slide where we talked about what we know, we do know that there can be a primary cause for pain that's directly caused by the multiple sclerosis, the central nervous system itself, that's causing the pain. And so that can be a primary cause. And remember, pain in MS is directly related to either that MS lesion or that plaque that's in the nervous system, and it's causing this type of sensation. And this can affect their disability. And as patients progress and they get more, they acquire more disability, then we also have to think about other causes for what can be causing that pain, because it may be secondary to these immobility issues or some of these other symptoms that they're having, and that can be contributing to their pain as well, because as they have more difficulty moving, now they can have an increased stress on muscles, on bones, on joints, and those can also cause pain. And usually that's more specifically talking about musculoskeletal pain. And MS can be worsened by a list of these things, and I haven't listed all of them here obviously, but pain in MS can be caused or worsened by infection, by pressure ulcers, by lymphedema, deep tissue injury, just immobility and deconditioning itself. I know I'm probably speaking to the choir here with all the therapy that you guys do, and how it relates to pain being affected by altered gait, altered posture, and just inappropriately being fitted for the wrong AFO or the wrong wheelchair. We do a lot of adjustments and referrals for that in our clinic, and that can contribute to the primary source of the pain, but it's related to a secondary issue that's not just caused by the lesions and the plaques that are affecting MS itself. And then we also know that pain can also be caused by tertiary causes. These can include psychosocial issues. We know that in our population of patients, they have a higher suicide rate when you're looking at chronic illness and demyelinating diseases compared to other central nervous system diseases and chronic illness. So we have to watch out for that. We know that they can have traumatic events. We know that it can be pain can be associated with the loss of a loved one, coping with their illness, and also just financial strains, losing their job, the economy. All these things can contribute to those sensory disturbances that manifest themselves as pain, but they come from these other tertiary causes. So I want to go over some what we think of how pain works, and I want to go over this slide. It does get a little complicated, so I'm going to try to simplify it as much as I can. But the reason that I picked this is because if you really grasp this theory, I think this is a great theory. It's called the gate control theory. I think it's a great way to try to explain to patients how these connections are being made in the periphery and how they connect to the brain, and how it's very important that not only medication, but also all of these other behavioral and physical management treatment plans can work, as well as the emotions and thoughts that they can have as a patient, as an individual, how that can affect their experience with pain, and how multiple approaches, trial and error, has to be tried because we don't yet have a certain way to know exactly what's going to work the first time we prescribe a therapy for a patient that has pain. And so trying to get them to understand that just like with their MS, we sometimes have to have trial and error. We put them on one therapy and we have to monitor them, and that might not be the perfect therapy, and then we have to switch them to something else. And this may go on multiple different times, because if the patient's having breakthrough, we have to switch them to something else. But not to lose hope in that, but to stay hopeful, because we do have a lot of different things to try, but we have to find what works best for them as an individual. And there's not just a cookie cutter algorithm that we can go by that works for everyone. And so this theory, which I'm going to explain to you now, it kind of helps patients realize and maybe give an analogy for them so that they can understand how all these different components, the medication, the physical therapy, the occupational therapy, behavioral management, emotions, all of these things can go in to decreasing the painful sensation that they may be having. And so I hope this is a little bit bigger for you on your screen than it is on mine, but this is the gate control theory of pain. It tries to explain why thoughts and emotions can also influence pain perception, and it was proposed by Ronald Melzack and Patrick Wall, and they wanted to give a gate mechanism to help further translate what's happening between these pain receptors and what the brain is perceiving as pain, and then how different components like emotions within the brain can then also directly affect those pathways down into the periphery. And so the first box up there, there's three different scenarios here. So the first box up there, you'll see in each one of the boxes, rather, that there are small nerve fibers. These are the pain receptors, and you'll see that those are represented by the S in the boxes there in those three different scenarios. You'll also see that we have large nerve fibers. Now these are the normal receptors, and they will help control and regulate pain, and we'll talk about that in a second. Then we have projection cells, which are represented by the P's. There's one gray P at the top, and then there's those two red P's in the bottom two boxes. And those are the cells that basically kind of push or project those transmissions to the brain from those small and large nerve fibers. And then we have the inhibitory neurons that are within the dorsal horn that kind of turn off or help turn on those different responses that get through to the projection cells up to the brain. Now, before I go any further, I just want to tell you that to a lot of our patients, if we kind of explain this to them in the way that we explain MS, it makes a lot of sense. And the way I explain it to them is, just like in MS, we know that we have immune cells that are attacking the central nervous system. And you want to have some good immune cells, because good immune cells help fight off infection, they help fight off tumor and cancer cells. They're there to kind of help keep the body safe and protect it. But then in MS, we also have those attacker cells that are misbehaving. And they're doing something, they're attacking the nervous system when they shouldn't, because they think the nervous system is a foreign invader, and they're attacking when they shouldn't. And that's what's causing these lesions and plaques in MS. And so those are misbehaving. Those are the bad guys. And we try to suppress those bad guys so that the good immune cells can do their job. Well, in a similar way, if you think about these projection cells, these P cells right in the middle of your screen in these three different scenarios, these are the gates. And just like the blood-brain barrier, these projection cells, act as the gates to the brain. And they dictate what helps get through to the brain, and then what from the brain gets pushed out back to the rest of the body. And so I try to help the patient see that it's a gate. It's just like your blood-brain barrier. We have to keep the integrity of the blood-brain barrier there to keep the bad guys out, but we'll still want those good guys to get in to help protect the body. And so these three scenarios here interplay with these connections, and they determine when a painful stimuli actually reaches the brain. So when no input comes in, these inhibitory cells, which in the first picture, the eye there is located in that yellow circle, those inhibitory cells actually prevent that gate, the projection neuron, from sending signals to the brain. So if the gate is closed, then those signals of pain don't get through to the brain. And so there's no input there, so the gate is closed. Now, if we look at the next box, now we have the gate is still closed, but how does that happen? Well, normal somatosensory input, when there is more large fiber stimulation, and remember, those are the normal receptors. So when they're kind of overriding and they work that pathway, you can see how then the inhibitory cells in the middle are no longer yellow like they were above, but now they're green. They get stimulated. And so they actually help keep that normal response going up to the brain. And so you'll see that the projection neurons are stimulated, but the inhibitory neuron prevent the projection neurons from sending signals to the brain. So again, the gate is still closed, and there's this normal sensory feeling. And obviously you want some normal sensory sensations, because if you touch a hot stove, you want to make sure you get that impulse to the brain to tell you to remove your hand so you don't burn your hand. But what we're talking about is suppressing some of those bad guys, those small nerve fibers that are those pain receptors that are causing pain in our patients. And if they're persistent, they're chronic, they're misbehaving, those are the ones we're trying to inhibit. Now in the last one, you'll see this is a good representation of maybe what's happening in a lot of our patients. These small nerve fibers are stimulated, and this inactivates the inhibitory neurons, which means now this P, the projection cells, are now turned on, which means that there is a signal getting sent to the brain, meaning the gate is open. And so you can see how with our patients, I can equate this with the blood-brain barrier. And if a lot of these bad guys in MS, we're talking about these bad attacker immune cells getting through to the brain, they can cause inflammation, they can cause plaques and lesions that cause MS. In a similar way, if these projection cells are open, the gate is open, these pain receptors, these small nerve fibers, can get through, they project to the brain, and they cause the sensation of pain. And if this pathway persists and it's continuous, then they will have these painful sensations that lead to chronic pain. And so I hope this kind of gives a good idea of a model that we can use to talk to the patients about. We need to keep your gate closed. We need to make sure that, sure, you have proper sensation, but we don't want you to have too much or too little. And that there are many different mechanisms, just like when we treat your MS, that we can use to treat pain. And so a lot of this can also come from the emotions themselves, which are triggered from the brain. And we know a lot of this from functional MRI studies, that even just emotions themselves, patients being less stressed, less anxious, that then the brain can transmit through these projection cells back to the rest of the body and inhibit these pain receptors, thereby decreasing pain. And so there's a lot of different aspects or components to the treatment plan other than just placing a patient on a medication to help relieve their pain. So I know that's kind of a roundabout way of getting to that, but what I'm hopefully getting across to the patient is that although this theory doesn't explain everything about pain perception, it does explain some things. And so I try to tell patients, just like when you rub or shake your hand after you bang your finger, that you stimulate this normal somatosensory input to the projector neurons, and this closes the gate and reduces the perception of pain. And so something as simple as, and we'll talk about these different strategies, these behavioral management strategies, massage, physical therapy, all of these different types of things can help reduce pain in that same manner. So what are the types of pain in MS? Well, we're not going to talk about a lot of these in detail, but I do want to go over the different categories that we can see specifically related to MS. Of course, I'm sure you've heard of patients talk about the first time they were diagnosed. Their symptoms could include this AON, that stands for acute optic neuritis, and the TM stands for transverse myelitis. And both of these are the two most common presenting phenomenon when patients are diagnosed with MS. They can have visual blurriness. They can have an inflammation of the optic nerve that can or cannot cause pain behind the eye, and they can have the transverse myelitis, which I'm sure a lot of you are well familiar with. So those can be contributing factors to pain. They can have acute or paroxysmal types of pain syndromes. We've talked a little bit about the trigeminal neuralgia. Again, that's a really important one to immediately address, because I can just imagine how impactful that can be on a patient's quality of life. And that is, again, that electrical shocking or that stabbing sensation in the face. It can occur as an initial symptom at MS, but it is very rare. And a lot of times patients may get referred to a dentist because this can be confused with dental pain. And we do want to make sure that their dental workup is normal, but we also have to make sure that this can be a type of neuropathic pain that can be damage done to the trigeminal nerve itself and does need to be addressed in a separate way from whatever dental care that they need. And we'll talk about those treatments, I think, on the next slide. Lhermitte's. I don't know if you've heard of this Lhermitte's sign. Patients may tell you that they have a brief stabbing electrical shock when they flex their neck. So it runs usually from the back of the head down their spine, and it's brought about by the bending of their neck moving forward, so the flexion of their neck. We know, as we talked about before, and as you heard from Amy a couple weeks ago, that pain can come about from tonic spasms or a lot of the chronic spasticity type issues that our patients can have. These can be spasms or cramps. They may occur more at night, which we usually try to triage and filter those types of symptoms out, because the patient may have another underlying condition, such as restless leg or something else, but the spasticity itself can be very painful. And we know, too, that patients can have chronic pain. So the spasticity can also be chronic, as well as the spasms. They can have joint pain, pressure related to skin pain, nerve injuries. But the most common type of chronic pain that we see is this dysesthetic, burning, tingling, aching, throbbing. A lot of patients may describe it in different ways, but it is this burning pain called dysesthesias, and it is the most common type of pain-related symptom in multiple sclerosis. Now, we can't forget that sometimes our patients have pain and it's due to other causes, not just their multiple sclerosis. And this can include infection, which we often rule out, headache, inflammatory conditions such as tendinitis, arthritis, and we've even had some patients coming in to our clinic and they think they have an MS relapse, and we end up sending them to the hospital and they end up having pancreatitis, appendicitis, they need to have their gallbladder removed. So we never want to keep other causes outside of MS outside of the forefront of our mind when they complain of pain. And then one thing as a nurse I never want to forget is that this can be therapy related. A lot of our patients are on injectable therapies, and taking injections mean they can have injection site reactions, and this can manifest itself in skin breakdown. They can have bruising, they can have welts if they're on certain medications, and we do have to watch to make sure that they're injecting properly, their technique is good. And so if you do have a patient in your clinic and they are complaining of pain, ask them what therapy they're on. Ask them how their injections are going. And sometimes this even means, well, can I see where you gave your last injection? And sometimes the pain-related issues have been more superficial because they are related to those injectable site reactions rather than MS pain itself. And that is a whole nother topic. But if we go down that road to treat injectable site reaction type pain, that's much different from treating a lot of the other pain-related syndromes that we can commonly see in MS. So now MS can affect every system of the body. And I know you've already had your MS 101, but this is not, I'm sure I'm missing some symptoms on here, but this is a list of most of the common symptoms of MS. You have to remember that all of these get integrated together. They're all stemming from these lesions and plaques that are forming on the brain and the spinal cord. And I know fatigue is usually brought up as the most common, which is, over 90% of our patients will complain of this kind of bone-crushing fatigue. But one thing I want to remind you of, and this didn't bold, but I had this kind of underlined as far as an animation in my slide. I don't know how many of you actually know or hear about our patients talking about how they're heat sensitive. And this is very, very important. And I'm not sure if Dr. Pardo went over this at all, but this can directly impact how we treat someone who's dealing with some pain. And so this is a picture of Dr. Wilhelm Uthoff, and he was the first one to describe this phenomenon in MS in 1890. And what this essentially means is that he had patients that were coming in, just like we see today, and they think they're having a relapse. They think they're having a new neurological event. But what's actually happening with these patients is they're having a reemergence of old symptoms. And this can happen, at least from the research that we've done within our group, by only 0.8 to 1 degrees Celsius of an increase in their core body temperature can elicit this reemergence of their old neurological symptoms related to MS. And what we know that's even more striking about this phenomenon is that if we cool down that body temperature, we get them back down to their baseline body temperature, we know that those symptoms will resolve. They'll go back to their baseline. So we call these this phenomenon, sometimes you'll hear the word pseudo-relapse. And so what this means is the patients are really experiencing this reemergence of symptoms. But what we know is that this is not indicative of a brand new relapse or exacerbation. This is not new activity that's going on if we were to perform an MRI. What we know is that something has caused even just a marginal increase in their core body temperature, as little as 0.8 to 1 degrees Celsius. And because of that increase in core body temperature, a lot, not all, but sometimes all, some of their symptoms will come back. And the minute that you get that temperature back down, the symptoms go away. Now, what causes the increase in their core body temperature? Well, that can be a lot of things. That can be infection. Now, the patient takes their own temperature orally or in their ear or across the forehead, and they don't notice much of a difference. But that's because those devices used to test temperature are only good if you really have a significant increase in body temperature. But we're talking about what we've seen in our research lab is a small increase, 0.8 to 1 degrees Celsius. So that can be equivalent to a patient who maybe gives a urine sample and it doesn't even have evidence yet of a full-blown urinary tract infection, but something's brewing in the bladder, and it increases that core body temperature slightly to the point where now all of a sudden their pain reemerges, and it's worse. And so what's the cause of that pain? Well, if normally at baseline they're on medications and they're stable, now all of a sudden the pain is worse, but it's because of this underlying infection. And so we know that our patients have this heat sensitivity issue, and so the first thing we do as nurses is we try to triage those symptoms and pull out, is this infection? Is this related to Uthoff's phenomenon? And if you treat the infection, or if, let's say, the patient is experiencing increased pain with exercise, that also increases the core body temperature. And also with some women who have a lot of symptoms around the time of the beginning of their menstrual period, we know that this time of their menstrual period also increases core body temperature. And a lot of these different variables can bring about these sensations of pain that maybe are normally controlled, but now they get a little out of hand because of this Uthoff's phenomenon. And so if we treat the underlying infection, If the patient stops exercising and cools down, if they come in from the hot Texas heat and they drink some cold liquids or get a popsicle, or they use the cooling vests that are available from the MS Society and a lot of other resources, if they get a good night's rest, if they manage their stress better and they're not arguing with their family members over the holidays or whatever it is, if we can decrease that core body temperature, those symptoms go away, back to their baseline. And so one of the first things we do when trying to manage pain is, if it's worse, we try to ask, what else is going on with you? Is there an infection? How did you sleep? Have you been sick lately? Is it around the time of your menstrual period? Have you been outside in the Texas heat or at one of your kids' soccer games, and now all of a sudden it's the summer and we know that it's a lot hotter? And so this can relate to pain management, because ruling out this phenomenon can potentially keep a patient from starting a new unnecessary medication for pain, when really all it has to do with is treating this underlying symptom to resolve this UTOFs phenomenon. And there's a medication that I don't know if it got mentioned at previous talks, but Ampera. And Ampera, although it is indicated, specifically approved by the FDA for multiple sclerosis, it is approved for walking and improving walking in our patients. Excuse me. But in our physiology lab at UT Southwestern, we will be hopefully publishing some data very soon to show that this UTOFs phenomenon can be impacted and helped mitigate the effects of this phenomenon by using a compound like Ampera. And so hopefully maybe in the future we'll be able to show that if patients are heat sensitive, that is bringing about their pain, that we will be able to use a compound or a medication like Ampera to help with those heat sensitivity, and then subsequently also helping with symptoms like pain if patients have difficulty with that heat sensitivity issue. So when we assess patients, what do? Well, we try to track their symptoms. A lot of times you'll see the analog pain scale being used. It's the 1 to 10 scale. Like I think I've belabored enough to you tonight, the importance of ruling out infection. We often, this is more for nurses, but we often take a urine sample. We do a urinalysis, a urine culture, to see what kind of a bug is actually in the bladder. And then we may do some blood too, a complete blood count, a comprehensive metabolic panel, just to see if they have high white blood cell count. We also try to determine the etiology of pain, and we'll talk about that a little bit. And then we try to rule out other non-MS causes and refer if needed. And often that's to you guys in the audience. So how do we treat pain? Well, I've talked a little bit about the non-pharmacologic strategies. Some of these are behavioral management and social support. So if we can really provide education to patients and their family members and their caregivers, and empower them that this is not just, sure, it's taking medication if you need it, but it's also some of these other components, just like we talked about with the gate control theory, where if we can get the patient expressing more positive emotions, they feel more hopeful, they can move more, and they have more activity going on in their life, then we know that that can directly impact their level of pain and possibly improve it. And so those things are important to include when you're talking about a treatment plan for pain. We need to encourage accurate, descriptive reporting of pain-related symptoms. Now, not only do we ask patients to maybe journal their symptoms so they remember when they come to their appointments, but they can use phone apps now to document their pain and track their symptoms over time. We do want to emphasize this interaction between mood and pain, and that's why it's so important to also make sure that they're getting good counseling, that we're helping them with any psychosocial issues they may be having, because if those aren't properly being managed, that can increase their pain and tolerance for pain. Enhance social support, which I think the MS Society does a great job of trying to decrease isolation in these patients, get them out, get them moving, and get them involved, because we know that that helps. I don't need to talk about these strategies as far as physical management, because I know you're all experts on that, but stretching is important, exercise, and then properly fitted mobility devices. And we see this all the time. Patients need to be fitted more properly, or they decide not to use their device, or they rig it in some way that is really causing skin breakdown or other areas that can cause pain. And then sometimes we do need to intervene with surgical management. We do know that for refractory trigeminal neuralgia, we may need to refer them for a surgical procedure to help get rid of that pain and that syndrome if medication management isn't working. Now, as far as pharmacologic, and this is outside too of some things that I'm sure you guys have some great tips on giving to patients. I've heard some people report to me that, well, if we can have the patient wear pressure stockings or gloves, then maybe this can convert the sensation of pain to more of a pressure-like symptoms, and maybe that helps patients because they can perceive the pain in a different way that's a little bit less disturbing. Maybe warm compresses to the skin, and then maybe using some over-the-counter medications, but of course that's under a physician's supervision. And we do know, again, that that people who stay active and maintain positive attitudes are often able to reduce the impact of pain on their quality of life. So I'm not going to go through the specifics of all of these. I'm going to kind of go through the categories of pain management that we most often see, since I know a lot of us on the phone aren't prescribers ourselves. We often use anticonvulsants to help treat central neuropathic pain. These things can include gabapentin or Neurontin, pregabalin or Lyrica. These are very common for first-line use for neuropathic pain conditions. They're usually cheap. They're indicated for neuropathic pain, and we know that they are effective in patients with multiple sclerosis, even though they're not directly indicated for MS by the FDA when they got approved. We know that we can escalate doses, and so it does give us a wide range of opportunities to help treat our patients. And then carbamazepine or Tegretol is also an important first-line therapy that we often try to put patients on for trigeminal neuralgia. We use antidepressants to also treat central neuropathic pain. The tricyclics are very common, and this is a typo here too. It should say Cymbalta and not Celexa, so I apologize about that. But Cymbalta was approved by the FDA in 2004, and it was indicated for not only the treatment of depression, but also to treat pain associated with diabetic peripheral neuropathy. And so we know that it belongs to this group of medications called SSNRIs, and though it's not specifically approved for multiple sclerosis, we do know that its effectiveness in diabetic neuropathy makes it a suitable candidate for treating neuropathic pain in MS. We know that sometimes patients may get Botox injections, and this can help with painful spasms, but we also know that we can use this off-label for neuropathic pain, and that it can also be used to help treat MS-related conditions such as bladder spasms, tremor, other common symptoms that we see in MS. The opioids, although you probably don't see these as readily, in our clinic we definitely use them, and there is a place for them in the right patient. And sometimes, if you think about it this way, we can combine these controlled substances, and often they're Schedule II, so they do require a triplicate from the patient, which can be inconvenient to some patients. But if we can combine these opioid medications with some of the other central neuropathic type of medications, then this may show support that there's this synergistic relationship between the two. And so if we put the two of them together in combination, we may be able to keep them at a lower dose than if we were only to put them on one agent alone. NSAIDs and acetaminophen can be used for musculoskeletal pain. We can use topical agents like compounded topical lidocaine or EMLA cream. These are for more of those superficial type pain sensations that patients can have. There's a whole list of them, and if you have questions we can go over those. We can also use ethyl chloride, which is a spray that patients can even use before they give their injections if they have injection related pain. I know cannabinoids come up frequently. It's not something that we see a lot in our clinic. We do have to consider the effect that those medications or those substances can have on cognition. And then again, the drug combinations can be helpful if we can maybe put a patient on multiple medications and lower their dose versus putting them on one large dose of one particular medication. And so combining at lower doses may increase efficacy with less sedation. So how do we choose which therapy? I mean, I briefly just took a glance at them on one slide. Well, how do we decide which therapy? And I tell our patients, I wish that we had a biomarker, and we're getting there in research, but I wish we had a biomarker to show let's draw your blood and let's figure out if you're a responder or a non-responder to one of these different therapies. And we're just not there yet. But if we could come up with the ideal medication, we would want one that's consistent as far as the outcome in randomized clinical trials. We'd want, obviously, a high degree of pain relief to help them quench those symptoms. We would want to have a persistent effect with less side effects. And we want them to be tolerable, and we want them to have an effect on their quality of life, and we want them to be low cost. And so we try to figure out which medication for that individual patient gives the most bang for the buck, and maybe includes most of these bulleted items to help the patient the most. So if the patient calls the clinic or sees you at an appointment and complains of pain, what do you do? And this, again, is from a nursing perspective. This is how we triage pain if patients are talking to us in clinic or they call into the clinic over the phone. First thing we do is we rule out infection. We want to inquire about their signs and symptoms. Most often, it's a urinary tract infection. And again, this is because it brings about those symptoms related to Uthoff's phenomenon. We want to know if it's a new symptom versus old. This can help tell us, is it because of that Uthoff's phenomenon and it's an old symptom that's reemerging, or is it brand new and now we're thinking maybe it really is something going on in the central nervous system and we need imaging. They may need to come in for a neurological exam. When did the pain start? Where is it located? Is it persistent or does it come and go? And then describe the type of pain. And we usually quote what the patient says to give us a good idea. And we ask them about agents that they've tried in the past, and then what medicines are they currently taking. And this gives us a good idea of maybe now what are the options to try. If we know that they've been on various agents in the past and they haven't been helpful, then we may want to revert to something else to try to help them. So overall health and wellness, we know that movement means improvement. And I can't express this enough, as I'm sure you do in your practices, that you can't neglect the impact that overall health and wellness can have on an MS diagnosis and with pain. There's a patient that comes to mind that I saw for about 2 years, and she just struggled with her diagnosis. She had pain, she had fatigue, she had headaches, cognitive deficits, insomnia, dizziness, vision changes, and this was just causing a lot of fear and depression in her life. She had 2 children that had to take care of her. They basically had to do everything for her. She spent most of her days in bed. She had chronic headaches. She struggled with lack of motivation, an exorbitant amount of fatigue. And she had always been adherent to her injectable therapy. That was never a question. We knew she was taking her therapy. And radiologically, she looked stable. But her symptoms were just, I could never break the cycle with her. And so one of our recommendations, and she was always open to them, was to just simply choose an activity to achieve some sort of level of physical activity each day. And she was reluctant at first, but then she decided that she would try attending 1 aquatics class per week. And I know at the time she was probably thinking, how is me expending more energy going to make me more energetic? And I know you hear and probably preach this to your patients all the time. But she began by attending 1 aquatics class, and she decided to then go with her friends. And the community pool was cooler for her because she was a heat-sensitive type of a person. Her friends would give her a ride and then go to class with her. And now she takes aquatics twice a week. She's sleeping better. Her headaches are completely gone. And because of this physical activity, she's probably reduced 3 or 4 different medications that were given for pain that she's no longer on anymore. She now takes Zumba for 15 months weekly, and I've tried it, and I don't know how she's even able to do that because I feel like it's so difficult, but it's a lot of fun. And now she's going window shopping for exercise. She's lost over 10 or 15 pounds just in the last few weeks to a month. And now she's even trying to take a trip to Jamaica with about 10 other women. And this is a huge, huge goal for her because she stopped flying when she had a diagnosis of MS. She didn't want to get in a plane because she was worried about the fear of having this dizziness and these visual changes return. But she feels so much better that now she feels encouraged because of her healthcare team, because of her family and her friends that have been able to help her. And now she has more stamina, which then only invests in lessening her progression and disability over time. And I can just see now that she was just completely overwhelmed and overloaded with these sensations of pain that with just a little bit of movement, she was able to escalate that regimen in her life, and now she's smiling. She wears really bright colors compared to the black and the grays that she used to wear when she sees me, and she loves to talk about how she can take care of herself while her children no longer have to do everything for her. So I know we're running out of time. I want to make sure we have at least a little bit of time for questions. There are some resources here in your slides. I do want to point out that we do have a nurse practitioner's handbook that I co-authored with two of my colleagues, Diana Logan, who's at our center at UT Southwestern, and Carrie Samarco, who's up in the Northeast, with Rosalind Kalb. Dr. Kalb is the editor here, and this is what the book looks like. You can get it through the National MS Society's website. It is free, and it will go through a lot of the symptoms that I think are hopefully a good handbook. It's supposed to be able to fit in your lab coat pocket, and you can download that for free on the MS Society's website, and further look at how we treat symptoms, not only pain, but everything that we deal with patients that have MS. Now, I can't see how many of you recognize who this is, but this is Florence Nightingale, and I mention her because she's the pioneer of nursing, but I'm also a research nurse, and I feel as though she was the first research nurse. She was not only a nurse, but a statistician, and she really implemented some very basic, fundamental techniques in hygiene that in some areas it's reported that she was able to decrease mortality rates by up to 50% just by trying to gather information and analyze it in a way that showed that just simple hand washing, opening up windows to bring in better ventilation, these types of simple fundamental things can help our patients, and in a lot of cases can decrease mortality and morbidity in our patients. And she was known as the Lady with the Lamp. And this is a picture of her bringing in soldiers during the Crimean War in the 19th century when she practiced. And so she's called the Lady with the Lamp because she provided that light, that hope to our patients, that when they saw her coming in the corridors at night with this lamp, they knew that she was coming to tend to them. And so I hope, in a very similar way, that our patients, when they see us, they hear our voice on the phone, that they automatically have this installation of hope, that we have many strategies to help them, and that there are many options for them, and not only helping them with pain management, but with all aspects of improving their quality of life if they have multiple sclerosis. And so this is our village. We have a large group of people, anybody from immunologists, sleep medicine doctors, our medical assistants, our PT, OT. We have 2 dedicated social workers. We have a whole core of research staff. We have more than a handful of nurses, nurse practitioners, physician assistants, just to further underscore that it really does take a village to help this multidisciplinary team to help treat our patients effectively with MS. And so I thank you so much for your time. I do want to have time for questions, and so if you'd like to type those in, go ahead and let me know if you have any questions, and then please, again, don't forget, before you exit out of your web browser, you will be able to take the survey and the post-test at the end. So thank you very much. And I know that there are about 33 or 35 of us on the line, so if anybody has any questions, we do have a few more minutes. I don't want to take too much of your time, but I do want to allow some time for questions. Besides surgery, what else do you do for trigeminal neuralgia? Well, surgery obviously is something that we don't want to go to first. Most of the time we're putting those patients on Tegretol, and that is a medication that we do have to monitor closely for side effects, and it's also a titration. So we start them on, the other name for that is carbamazepine, and so we start them on Tegretol, and we tell them you need to get this started right away, and we do need to escalate you up to a dose that works. And so there are, I didn't mention this before, but there are lots of those resources that are on that resource slide that will give actual dosing and titration schedules and routes of administration for those commonly used medications for pain management. And I didn't want to go over all of those because I know a lot of us aren't educating patients on specific doses, but the Tegretol is usually the first go-to type of medication. And then we do have a lot of those other neuropathic pain type medications that we can also try to use in combination, and then can try to escalate those to see if dosing strategies can work. It's also one of those things that can calm down and go into remission. So patients sometimes can be well managed on the oral medications themselves, but like you're mentioning here, and as I talked about briefly in my talk, that some patients do have refractory TN, and for those patients we do have them see a surgeon. And we have some that work very closely with our group. And there are different types of surgical procedures. There's the gamma knife, there's rhizotomy, and so there's different strategies where those surgeons can go back behind the ear and try to cut those nerves that are overstimulated, causing that painful sensation in the trigeminal nerve area here on the side of the face. But that, if the patient is not tolerating the oral medications, that usually is the most successful type of procedure to really cut off that electrical sensation for that type of syndrome. So for patients that do not respond to meds, is surgery the only option? Any name of a surgeon you refer to in Dallas? Well, I can tell for sure that we definitely have a handful of surgeons that we see that see our patients at UT Southwestern. We obviously have had success with our patients seeing them, and so we consistently refer to them on a regular basis. But like I said, if the patient's trying things depending on the patient, they may want warm compresses, cold compresses. I've had some patients tell me that they're eating ice cream, and for some reason they're very, very, very cold of the ice cream, or smoothies really helps. I don't know how common that is, but I have had some patients mention that. And then trying to find out any of these other underlying issues. They may need to see a dentist to really truly be able to make sure it's a diagnosis of trigeminal neuralgia. But yeah, a lot of those patients that do have refractory TN do end up going in for some sort of surgical procedure. It's not a lengthy procedure at all. The recovery is very good. And again, we do have a group of physicians that we refer to within UT Southwestern for that. Ashley has a question. You might have said this, but what is the prevalence of UTOFs of the patients that come in with pain complaints? That's a really great question. I'm trying to figure out your question here. So the prevalence of UTOFs, a lot of patients, depends on where you live. Some patients may be heat sensitive, but they don't live in warmer climates, so they may not even really realize how heat sensitive they are. So I think the patient reported outcomes from research that's been done on the prevalence is probably an underestimation. But when patients have pain, now if you're dealing with pain first and not the UTOFs phenomenon, now it's important to ask the patients, when you're experiencing an infection or you're out exercising and it's hot out, what symptoms reemerge? Is pain one of them? And for some patients it is, some patients it isn't. And then some patients may say, well, my pain does come back, but it's so mild, it's very tolerable because I'm on these other medications. But I do know that if I continue to stay out in the heat, or if I do continue to exercise, or if I don't treat that rip-roaring sinus infection, then I know that my pain will get worse. And so it's helpful to educate the patients to know about how to prevent some of these UTOFs type phenomenon so that their pain doesn't escalate. But we haven't formally looked at this in our center, but I would think that, I know that UTOFs phenomenon can be reported in as high as 60 or 70% of our patients. And so how many of those patients actually have pain? Well, it just depends on how many of the patients are experiencing pain as part of their MS symptom. And that can be, just like in our first couple slides, anywhere from 35 to 80%, with an average of about 65%. So my guess would be there that if patients are heat sensitive and 65% of them are experiencing pain at some point in their MS diagnosis, that would be a good estimate So it is a huge proportion of the patients you're probably seeing with MS. Now, to what degree they're aware of their heat sensitivity or that it's even related to MS at all is another story. And that's why I think I do a lot of education about that UTOFs phenomenon with them. And you spelled it correctly, so I appreciate that. Yeah. Any other questions? There was a previous talk about eStim for pain management. Yep, and he even noticed, yeah, so he even says here that per the last webinar, prior to surgery works great for trigeminal neuralgia. So Terrence, there you go too, that the eStim for pain management can also be a good strategy for helping deal with those symptoms. And again, because we aren't specialists in that area, we will refer patients to a pain management team, and they will do a workup if someone has refractory TN. So thanks, Keith, for that comment. But if it is refractory and those other strategies, those alternatives aren't working, and the patient is just in excruciating pain, and maybe we've tried steroids. Steroids, don't forget, are membrane stabilizers, and even though they're not indicated for pain, they may be a way to treat these types of syndromes where we need to kind of stabilize those membranes that are affecting those pain receptors. And in that case, obviously, it's in the trigeminal nerve. They will usually see pain management specialists, and then they'll also get a workup from the surgeon just to see if there's anything else that we can do for these patients before they go on for surgery. So comments. If anyone else even has any feedback, or if you have anything in your experience that you'd like to put out there, go ahead, because it'll be recorded and it's shared with everyone, so it'll be nice to kind of share that knowledge that you have with everyone else. STEM didn't work, but mostly because of patients' severe depression and inconsistent use. And yeah, but in some patients it can work. And I think that it's important to assess the patient as an individual, but don't leave it out as an option. Just like with some of the other strategies that we use with our patients, if eStim works great for one patient, it's definitely worth looking at, rather than just moving them right along the trajectory of some sort of surgical procedure. So it's always great to have a discussion with the patients and make sure that they know what the expectations are if they undergo some of these treatment plans, and so that they're well informed of what all of their options are, so that they can decide what's best in conjunction with their healthcare team of what's the best strategy to help with their symptom. And Keith has lots of ideas. So gosh, if you this is great, Keith. Thanks. And I'll definitely, I'll probably contact you as well, just so we can get some more information too, so I can be sure I can share with our faculty and other physicians when referring for trigeminal neuralgia pain. Thanks so much for that. Okay, and so we're going to go ahead and close out, because I think some of you might be waiting for the session.